Good morning and good afternoon. Today, the talk I'm giving is focused on PBPK modeling to support pregnancy and neonate clinical trial development. Many pregnant women need to take medications for the treatment of either pregnancy-related conditions such as hypertension, gestational diabetes, or for chronic disease such as asthma, allergy, epilepsy, depression, etc. And oftentimes they're given the standard dose because of the lack of PK data in pregnant population. And if you look at drug labels, many of the labels advise not to take drugs during pregnancy due to the absence of reliable safety data. And as a result, pregnancy studies are usually performed in the post-marketing settings, which causes delay in drug availability to the pregnant population. And in recent years, regulators have emphasized the need to facilitate the inclusion of this vulnerable population in clinical drug development programs, and also to provide recommendation on continuing treatment during pregnancy. And as you can appreciate, there are many challenges in conducting such studies in this vulnerable population. In addition to enrollment difficulties, there can also be challenges in addressing the selection of study populations, considering the gestational age, and also consideration of the physiological variability. And PBPK platform can play an important role here to address some of these challenges. And here is a schematic representation of a maternal pregnancy PBPK model. You can see that this is based on the full PBPK model, which defines all the key tissues or organs in the body, with the inclusion of this fetal placental unit. This fetal placental unit is essentially a lumped compartment that represents fetus, placenta, amniotic fluid, and uterus. Within this PBPK platform, various time-varying physiological changes are incorporated. These include weight gain, hemodynamic changes such as increased cardiac output and increased blood flow, increased blood volume, a decrease in albumin levels due to increased plasma volume, and increased renal function, and finally, but not the least, changes in CYP activities. As you can see in the example illustrated here, some of the enzymes such as CYP3A and CYP2D6 activity are induced, whereas for other enzymes such as CYP1A2, the activity is suppressed during gestation. A typical workflow for pregnancy model development looks like this. First, we start with building a drug model for the non-pregnant adult population using in vitro and in vivo data. And during this process, the impact of disease or ethnicity can be assessed if data are available. And then for verification, we need to ask the question, does the model describe the observed PK data in a non-pregnant population adequately? And if the answer is no, this usually implies additional drug-specific parameters needs to be refined or collected, and further verification steps will be performed, which is usually an iterative process. If the answer to this question is yes, then we can move on to the next stage, which is to incorporate gestational age-dependent physiological parameters and verify whether the model can adequately describe the observed PK data in the pregnant population. And if the answer is no, then this usually indicates that we need to collect more information regarding the gestational age-dependent changes in physiology, and then update the simulations, followed by additional verification steps. If the answer is yes, then this verified pregnancy PBPK model can be applied for different model application scenarios, including dose prediction, drug interaction assessment, fetal exposure assessment, and response risk assessment. So here are some model verification results. I will start with CYP substrates. The first example is theophylline, which is well-known CYP1A2 substrate drug. You can see that these results follow the typical workflow just mentioned in the previous slide. We have demonstrated that the theophylline model can reproduce the observed drug concentration in the non-pregnant population and also in the various gestational stages. And in this case, because CYP1A2 activity is suppressed, you will have an increased drug exposure during gestation. And more interestingly, if you look at the figure on the right, here we try to compare the simulated PK parameters such as half-life and clearance and overlay them with observed data, which are represented by these colored symbols. You can see that there's quite a bit of variability in observed data, particularly around the baseline assessment. And this highlights one of the challenging conducting pregnancy PK/PD studies, which is the baseline assessment. Has to be done at least 10 weeks postpartum. And a lot of these studies either used historical control or conducted the baseline assessment shorter than 10 weeks of postpartum, which may be part of the reason that explains a lot of variability in the data. Next, if we look at another drug, metoprolol, which is a well-known CYP2D6 substrate drug. Again, on the left, you have the model verification results for the non-pregnant population for various dosing regimens, including IV and different doses of oral administration. And on the right is the comparison of the simulated observed data, mostly in the third trimester. You can see that there's a good agreement between the simulated observed PK data in the pregnant population. So in the case of metoprolol, because CYP2D6 is induced up to threefold during pregnancy, a reduced drug exposure is expected in pregnant women. The third example we're going to briefly discuss is CYP3A4 substrate drug, midazolam. Again, we've demonstrated model performance in the non-pregnant population following both IV and oral administration. And then we then assessed model performance and compare it with data obtained in late gestation. You can see that there's a very good agreement between the simulated and observed outcome. And the panel E shows the simulation of drug concentration immediately after birth. And these are compared with observed data collated from pregnant women undergoing a C-section. Again, you can see that there's a very good alignment between the simulation and observations. So we've just discussed model verification results for various CYP substrates. Here we're going to look at one example for a drug that's mainly renally cleared. And because renal function is known to be induced during pregnancy, so in this case, we've used ceftazidime as an example to look at the performance of the pregnancy module for renally cleared drug. Again, on the top panel, we're showing you the model verification for the non-pregnant population. And at the bottom, these are the comparison of the simulated outcome and observed data following various dosing regimens, either with IV and intramuscular administration. Again, we're seeing a very good alignment between the simulation and observations. So after I discussed the model verification results for the pregnancy module, here I'm going to present a model application example. So this is a project that I conducted a couple of years ago. The main objective of this project is to evaluate maternal drug exposure following the administration of antenatal corticosteroids during late pregnancy using this PBPK platform. So some background information on this project. Betamethasone and the dexamethasone are the most widely used or studied antenatal corticosteroids administered to pregnant women just prior to the birth of a preterm neonate to accelerate fetal lung maturation. Although betamethasone is predominantly used in developed countries, the choice of antenatal corticosteroids and the optimal dosing in low and middle income countries remains unclear. And this is primarily because the exposure-response relationship has not been well established for these corticosteroids, despite the long history of use. In addition, the optimal timing of use, the dosing route and duration of the effect, and frequency of the administration remain unclear. So as a first step towards the optimal use of antenatal corticosteroids in low and middle income countries, we developed PBPK models to describe the kinetics of these two corticosteroids following IV, oral, and intramuscular dosing. So you've seen this workflow several times by now. For this project, we've also followed the best practice approach. First, we establish a model and make sure that the model can reproduce the observed drug concentration in a non-pregnant population. And the main focus of the model development is to verify the CYP3A component in the model, because both drugs are CYP3A substrates, and we know that the CYP3A4 activities are induced during pregnancy. So here you can see that on the left, we've used itraconazole DDI data to verify the CYP3A component with an estimated CYP3A contribution of 95%, which is in fact very close to the in vitro derived CYP3A contribution. And then on the right shows the model verification by simulating the drug exposure following IV dosing in the pregnant population and comparing to the observed data. In addition, the developed dexamethasone model was also applied to assess the relative bioavailability of intramuscular and oral administration in the pregnant women, and the results are comparable to the observed data. For betamethasone, we followed a very similar workflow. The unique issue with betamethasone is that there are two different formulations as shown here. So we have used a fit-for-purpose approach where we employed a first-order absorption model to describe the kinetics of these two different formulations. And then the developed betamethasone model was applied to assess the pregnancy effect on the kinetics of the drug following IV dosing, and the simulations are compared to the observations, which showed induced clearance during late pregnancy. And then for model application, the target steroid concentration in the human fetus is unknown, yet based on the exposure response study in sheep, a low steroid concentration maintained for roughly 36 to 48 hours will maximize efficacy while minimize the exposure to the steroid in a fetus. And for the low and middle income countries, the dosing option using both oral and intramuscular administration and converting between these two steroids are of interest. And you can see that for these reasons, we have applied the developed corticosteroid model and assessed multiple dosing conditions with different dose frequency and dosing route. And these results were then used to select suitable dosing regimens that is to be implemented in a dedicated clinical PK/PD trial. So far, we mainly focused on discussing the prediction of maternal drug concentrations. But another important component of assessing drug exposure is the fetal exposure to drugs. As you can imagine, if the pharmacotherapy is intended to treat maternal conditions, then in most cases, we would like to minimize fetal exposure to drugs. On the other hand, if the pharmacotherapy is intended to treat fetal conditions, then we want to make sure there's adequate exposure to the drugs in the fetal compartment. So for this purpose, the previously described maternal PBPK model was further expanded by the inclusion of this 3-compartment placenta model, which is then linked to this fully magnetic fetal model. And essentially, this kind of model framework allow you to define model transfer between the maternal and the fetal side. And normally this requires, for example, data from ex vivo placenta perfusion experiments or in vitro transport studies if the drug is known to be a transporter substrate. And this kind of model structure will then allow you to simulate not only drug concentration in the maternal compartments, but also umbilical cord, different fetal compartments, and amniotic fluid. So here I'm just going to highlight one example. So this is a drug that's used for treating bacterial infection that's mainly renally cleared. And you can see that using this type of coupled maternal fetal placental PBK model framework, we can simulate maternal plasma concentrations in umbilical vein, amniotic fluid, and various fetal compartments. And in this case, you can see that the simulated data are generally consistent with the observed data. So another important question that we need to address is how about neonatal exposure to drugs due to the intake of breast milk. And in recent years, we spent a lot of effort developing these lactation models. So here you can see that we have two different types of models. On the left is a static perfusion limited lactation model. You can see that it actually requires very minimum drug input parameters. It uses an empirical Q-cell model to predict the milk to plasma ratio. So this type of model does not account for low permeability of the drug or any transport kinetics. And if these are of concern for your drug of interest, then you can use the permeability limited lactation model, which then allow you to define different transport and passive diffusion processes. So both models account for the milk pH effect and binding to different milk components. So very briefly, I want to highlight this caffeine example. So here are the physical chemical characteristic of caffeine. And in terms of the lactation model building, it involves the following steps. First, we establish a model to make sure that it can predict the maternal plasma concentrations in healthy lactating women following different dosing regimens. And then a lactation PBK model was developed using this Q-cell model called Fleischaker, Atkinson, and Beger model to predict this milk concentration of caffeine. And then from this, we can then compute a milk to plasma ratio and then compare that to the observed milk to plasma ratio. And finally, we can derive a infant exposure in terms of the relative infant daily dose. So as described in the previous slides, these are the lactation model performance results. You can see that A and B represents two different studies, and we have the maternal plasma PK profile on the left and the milk PK profile on the right. And you can see that the predicted milk to plasma ratio are reasonably consistent with two different studies. And then from these, we can then derive the relative infant daily dose, which roughly represents 10% of the maternal dose. So how do we then use this information to predict neonatal drug exposure? This will be my final slides. You can use this type of workflow. So once you derive this infant daily dose from this lactation model, you can then use this daily dose as input to then simulate neonatal plasma concentrations of drugs using this neonatal PBPK model. If you want to find out more about the details of this kind of application, you can refer to the publication listed here. So in summary, we know that there are numerous physiological changes that are time varying during pregnancy that can impact drug PK. And within the PBPK platform, we can assess the impact of individual variability, either due to genotype, demographics, or enzyme activity. And we can also use PBPK model to predict the drug concentration in maternal, fetal, umbilical cord, fetal organs, placental tissues, and milk to plasma ratios using this maternal, fetal coupled model, in addition to the lactation model that we just described in several slides ago. And you can see that with these type of PBPK platform, we can then use these approaches to support dosing decisions by considering these various physiological changes. And because the PBPK platform incorporate population variability, this can also provide insight in drug disposition, where clinical data are usually very limited. And hopefully the results of these PBPK simulations can help improve the design of prospective studies in these vulnerable populations. And last but not least, we know that the confidence in these type of models are increasing in recent years, but model expansion and verification is an ongoing effort. With that, I would like to conclude my talk, and I'm ready to take any questions you may have. Thank you for your attention.